Get your gear ready. This is a Sherpa's Guide to Innovation.
I'm telling you now, buckle up for this episode of A Sherpa's Guide to Innovation, a podcast dedicated to guiding you along your innovation expedition. My colleague and Director of Innovation at Atrium Health, Ann Summers-Hogg, is here with me in the studio. Welcome, Ann Summers.
It's great to be back, Ben.
Today's guest is a healthcare wunderkind, a renaissance man. He's a scientist, entrepreneur, physician, biotech venture capitalist, policy analyst, machine learning pro, biomedical informaticist, and writer. He's currently a surgical resident at UCSF Medical Center and found time in his busy surgery call schedule to speak with us today from California. Dr. Nisarg Patel, welcome to a Sherpa's Guide to Innovation podcast.
Thank you for having me. It's a pleasure to be here.
Awesome. Thanks a million for joining us this morning, Nisarg. We're really honored to have you with us.
We're so happy to be here.
Now, at this point in the episode, I usually do a little reminder to our listeners about subscribing to this podcast, sharing it with a friend, giving it a rating and review and all that stuff, but I don't want to waste another precious minute on that, so let's just dig right in. Are you ready, Nisarg?
I am. Let's do it.
All right. First question. Fill in the blank. I wanted to be a blank when I grew up. Now I'm a blank, and they both blank.
So when I grew up, I would spend a lot of summers traveling to Southern California from Phoenix, where I was born and raised. And so I think, like a lot of 8 to 10-year-old boys, I wanted to be a marine biologist. I love fish, sharks, whales, anything under the sea, which could not be any more different than what I'm doing now as a surgical resident at UCSF. But I've got to say, they both involve, metaphorically diving into the deep end.
That's awesome. I'm sure as a resident, that's how you're feeling right now. Well, Nisarg, we've spent some time looking over your background, and it's clear that your interests and professional experiences are wide and extensive. Tell us a little bit about your background, and what do you think the golden thread is that ties it all together?
So I think hindsight is always 20/20 here. I have a problem where I like too many things, as you pointed out. And I think part of that is just that at different points in my life, I found different things to feel more important or to feel more compelling based on what's going on in the world, where I am in my education. And so in college, I had the opportunity to study both biotechnology and political science on my path towards surgery. And I never thought that these two very different fields of study would ever come together until I got to medical school, and there was this big debate over what we were going to do about U.S. healthcare. And I realized all of a sudden that a degree I had studied in college, essentially because I enjoyed doing policy debate in high school, became really useful in understanding what was going on Capitol Hill, as well as understanding how that was changing both the way that we built medicines as well as delivered those medicines and other types of healthcare services to our patients. And so over time, I found that these different threads, whether it be health policy, practice of medicine, biotech, health IT, started to come together in that you had policies that were essentially influencing the development of medical software devices and drugs, but you were also having a renewed voice and activism from physicians that was telling people, these are the problems that we have with the current technology in healthcare. This is what we wish we had. This is what we would like to change. And then understanding as a builder what I could do to change that. And so I think the more that I kind of spread my fingers into these different parts of health and medicine, the more I believe that, taking the time to understand all of them, or at least have a foundational understanding of all of them, is incredibly important just because of how interdisciplinary the field has become.
Definitely. And I was just thinking it's your multidisciplinary perspective that really allows you to excel and to bring such interesting viewpoints to healthcare that are so needed. And so thinking about your perspective in medicine and venture capital, what are some glaringly obvious things industry incumbents are overlooking?
One that I see very often is the idea of healthcare consumerism or shopping for healthcare. And the research just, continues to show that that simply doesn't work. And that's unfortunate. Healthcare is just unlike any other type of economic market out there. There was a recent study by Dr. Bapu Jaina at Harvard that looked at what doctors do, the kinds of medical decisions they make when they need healthcare, and found that they were no better than the average person. And so if the people who are supposed to have the most knowledge about healthcare and the practice of medicine can't determine or distinguish between low-value care and high-value care, how can we expect anyone else to? And so I found that you essentially have this market for lemons for healthcare, this information asymmetry where patients don't know what they're getting, and at the same time, the hospitals and healthcare systems that the patients are receiving this care at essentially can't give them a price or some sort of metrics of quality that will say this is the bang you're getting for your buck. And so I find that with all of this movement towards letting patients decide where to go, I understand that it can be empowering and feel good, but I also worry that it's putting too much pressure and too much burden on patients and other consumers of healthcare to kind of choose for themselves, often to the expense of their health.
So you mentioned a phrase that shopping for healthcare doesn't work. And your comment about information asymmetry is intriguing, and I'd like to dive into that a little bit more. So if we think about the fact you mentioned even providers who are supposed to be the most educated in this space, if they aren't able to intelligently choose where to get the best care, then how can we expect anybody else to do it? And how do you think in an age of consumerism, people are creating workarounds? So if there is information asymmetry, but they're still seeking to make the best decision about their health and their health care, what are they doing instead? If they aren't getting the best information from health systems or from their health insurers to direct them where to go, where are they getting it instead?
I think they'll use whatever proxies are available to them, whether that's a referral from friends and family, if it's something as simple as Yelp, anything that might give them an insight into either which doctor is closest to me or which doctor do people I know myself, or at least I'm willing to read on the internet, are telling me about where to go. And unfortunately, that kind of advice is often on one of two extremes. People are very rarely willing to talk about their experience in the healthcare system unless it was incredibly good or incredibly poor. And so I think that gives patients a very skewed understanding of the kind of care that they should expect when they go visit a physician.
Yeah, you really hit on something key there with the word of mouth component, and they get the suggestions and feedback from their friends about what they should do. And that tells us a lot about who consumers trust. And there have been a lot of studies lately across industries and specifically looking at healthcare in terms of how individuals' trust in health systems is not where it used to be. And I think we're seeing a big shift in consumers in that they're increasingly trusting the word of mouth of friends, family, etc., as opposed to what their doctor says to do. And even beyond friends and family, the role of social media influencers, or really just seeking the information in non-traditional ways because the traditional system has failed to give them what they're looking for.
Yeah, I absolutely agree. I think that there's a big problem of trust and lack of trust in science and medicine today. And we're seeing that both in how patients approach their healthcare choices, as well as some of the public health problems that we have around the country today, including the poor rate of vaccine adoption, which, is causing a public health crisis.
Right.
And so I think that involves both having more people with scientific backgrounds in positions of political influence. And I also think that it's important for people with those types of backgrounds to have a larger presence in the media. I think that, fairly or not, so much of public opinion is shaped by where they spend most of their time, whether that's online, on Facebook, in their community, watching television. And I think being able to get the right information to them is one of the most important things that people with this type of expertise can do.
Yeah, I've seen some of your Twitter comments about that, advocating for more scientists, more researchers, more people with those technical skills to be in positions of influence on a policy level, not letting it be dictated by Hollywood celebrities, but people that really know the work. So I'd agree with you there.
So let's talk a little bit about primary care. You've written extensively about this space, and with insurers moving into primary care, providers trying to respond, and startups emerging and now scaling, what does the future of primary care look like from your perspective?
I think a lot of primary care in the future is going to look like, for lack of a better word, convenience. When people have a medical problem, they don't turn to their insurer, they don't turn to their doctor. The first thing they'll do is turn to Google search and say, hey, I have a sore throat, a runny nose, I think I have a fever, what's going on? Where should I go? And essentially the primary care system of the future has to compete with Google in developing some sort of asynchronous communication tool, something like texting your doctor or someone on the care team to say, these are the concerns I have. One, how, at least from this interaction, how serious do they think they are? Where should I go? And I think that does a couple things. One, it changes the idea of what telemedicine is. I think that the idea of talking to your doctor over your laptop screen or your iPad is essentially the same as an in-person visit, short of the commute that it takes to get there, right? The interaction is not very different. But if I have a busy work schedule, have a lot of other things on my mind, but I would love an answer to whatever healthcare question or concern I have, then being able to immediately text someone and then, not urgently need an answer, but get one within the next few minutes, the next hour, would be a great way to continue doing whatever I was doing for the day, but also understand that I'm able to get these responses, get the service I would expect from the healthcare system at my convenience. And then that does another thing for the healthcare system, which is saying, all right, based on what we've heard from this patient, do we think they should come into our primary care clinic? Do we think they should go to urgent care? Do we think that this is something serious and they need to go to the emergency room? That point of triage is really important. And I think that that's something where a lot of insurance companies and a lot of health systems just haven't had the level of engagement or, first point contact with patients to be able to sway their decisions. And as I mentioned before, like patients and even doctors don't really know what the best point of care is for them. And so they'll often either shoot too low and hold off, maybe hold off going to the doctor for a few days, or they might think it's an emergency and head straight to the ER.
Right. So you mentioned convenience and the ever famous Dr. Google. Are you familiar with the model 98.6?
I'm not, other than the temperature reading.
Okay, so you've got to check this out. It's 98.6.com. And it is everything you described. It's changing the idea of what telemedicine is. It is convenience to the nth degree. And what 98.6 does is they pair an automated chatbot and a board-certified physician. So it's Dr. Google, only it's actually a doctor. So you download their app, you interact first with a chatbot who effectively triages you, figures out what's wrong, gives you a likely diagnosis, but doesn't actually give it to you, gives that information to the board-certified physician, who you then only have to interact with for maybe 2 to 3 minutes before you end up with a diagnosis, a care plan, and a prescription if needed. The best part about this is it's $20 a year for your first year. You could interact with this thing every day for $20 a year. It goes up to $120 the second year, but on a high deductible health plan, most people can't even see their primary care physician once for $120. So your definition of convenience and changing the idea of what telemedicine is, that's what 98.6 is doing. And they're no longer just going direct to consumer, which was their original approach. They have now started to partner with payers, and last month just launched a partnership with Banner Aetna in Arizona, and they're now available to over 300,000 of their members. So we often say when we talk about the potential disruptors in the primary care space that many will fail, some will succeed, and one of the most important things is who's running the show. So who's the leadership team behind the organization? And with 98.6, their chief product officer is actually the individual from Amazon who was responsible for scaling Amazon Prime from thousands of users to millions. So this is one that I always say to incumbents, watch them, because they're going to be a threat.
Yeah. And I think what's interesting also, as you talked about, Nisarg, is if convenience is going to be such a premium, and there's already that hurdle that health systems face with that trust factor with patients. So it's not only overcoming that trust deficit where they feel comfortable coming to a provider with their questions, but also creating that engagement that hasn't yet been there before. I mean, so that's a tall order to make that change. Yeah, it's interesting to see how many players are trying to figure that out. And you actually co-founded a health tech company doing communication in Memora Health. I think you were Y Combinator backed startup. Tell us a little more about that and the problems that Memora Health is trying to solve.
Yeah, absolutely. Memora Health came out of a course I took as a first-year medical student called Patient Doctor 1. And essentially, it was a 2-year-long course where we learned how to do a standard history and physical exam on patients in one of the Boston teaching hospitals. And I go into one of the hospitals every Monday morning and look for a new patient to interview along with one of my faculty members. And I started to notice around the December of my first year that some of the patients I had interviewed the prior Mondays and had told me they were being discharged the next day or that Wednesday were back in the hospital the following week. And so there was one Monday in December, I walked into a patient's room. She was suffering from heart failure. And I asked her, hey, I interviewed you last week. I thought you were going home. What happened? And she simply had so much trouble managing her condition at home. There was a stack of discharge instruction paperwork, verbal instructions that she had received from both her physician and her nursing staff. But it was so much information to take in. Those papers get lost. There's so many of them. It's hard to read through all of them in time. That she just had trouble eating the right kinds of food. Ended up with what we call fluid overload, and that sent her back to the hospital. And so I noticed at the same time that she was talking to me, she was also texting her grandkids. And that got me thinking about taking the idea of some of these, complicated, often time-sensitive discharge instructions and moving them to something that patients will always have access to, can easily interact with, doesn't involve learning any new technology. And that's where the idea for the company was born. And so that same December, I was texting a friend of mine from Atlanta who I'd grown up with in Phoenix and said, hey, there's a hackathon happening at the University of Pennsylvania this January, and it's being sponsored by their School of Medicine. Do you want to go check it out? And he said, yeah, that sounds like fun. It'll be a good chance to hang out, catch up. And over the 36 hours of that weekend, the third weekend of January in 2015, we built the first prototype of what eventually became Memora Health, which at the time we not only thought was interesting because it would text patients to take their medications on time. And by the following morning, we realized there were 500 apps that did that. And so over the next 6 months or so, we began to move discharge information to it. We talked with a lot of my professors, physicians in the area to understand what they thought was important to get to patients once they left the hospital. And that was anything from instructions after they had trauma surgery, orthopedic surgery, managing diets and blood sugar control for patients with diabetes, understanding weight, the right types of foods to eat, and movement for patients with heart failure, as well as helping postpartum women manage how to deal with their new baby, to deal with things going on in their own bodies. And over time, we just got better and better with understanding both what physicians wanted from the service, as well as how exactly to frame it to health system executives when we were pitching it. And so something that, is both disappointing but also eye-opening is that at first we thought that this would be something that would help reduce readmission. So we can take better care of patients at home with discharge messages that were sent to them at the right time, then, the chance that they'd be readmitted to the hospital would be lower. But there are 50 pitches a day to the hospital COO or CFO about reducing readmissions. And there's an attribution problem where even if you see the results you like, you don't know what intervention that you've implemented is actually leading to that change.
Yeah.
And so what we ended up realizing was that, 50 to 60% of a hospital's budget, and it's growing year over year, is labor costs. And it's often additional administrative workers that are often doing the same thing over and over again. So we noticed that some hospitals had been hiring or building their own call centers to follow up with patients. And we really appreciate that type of human touch with patients. In fact, Accolade, for example, is a great example of how this can work at scale. But we found that for a lot of patients with similar conditions, 60 to 70% of those conversations were very easy, very simple checkups. Say, hey, Sally, have you measured your weight today? Are you making sure you're avoiding salt? Have you been able to move across the house? And in those cases, if you can automate the follow-up to those 70% of patients who are going to be okay without a human on the other line, that frees up time for your existing labor force to take care of the 30% that really need that additional human touch. And so for us, that was both a way of tackling a huge inefficiency in the healthcare system, but also just making the lives of those healthcare workers a little bit better.
Yeah, I mean, that's a win-win type of situation. And I'm sure you've learned a ton about technology and where it works and where it doesn't. What are your thoughts about where technology should be applied and where does it not make sense? I mean, it's clear that technology is an enabler and not a panacea. And from your perspective, having done some of this work on the ground, where does technology work and where does it just not work?
I think there's a lot of low-hanging fruit in healthcare in regards to what types of solutions has technology been able to automate in other industries that we can apply to hospitals and other healthcare practices, as opposed to what currently gets all of the attention right now, which is the trope that AI will replace doctors. And so I think solutions that are looking at, say, making radiology scans faster or automating a lot of menial labor, whether that's billing, coding, phone calls, a lot of front office and back office work that makes it a lot easier for the existing staff in those positions to do their job. At the same time, I also think there's an opportunity for technology to look at some of the existing patient data to understand what services and treatments are working well and what maybe aren't working as well as we expect them to. I think the idea of using technology and machine learning for clinical decision support, that is automating diagnoses or automating treatment decisions, is a little more far-fetched simply because there's so much, for lack of a better word, messiness in medical data that often you'll have these amazing results published in scientific journals about how this new machine learning algorithm was able to predict, say, acute kidney injury. This is my recency bias speaking. But in the real world, when you have a very messy data set, you have a lot of fields, a lot of lab values that just don't have any inputs. It's difficult to get that same level of performance, particularly over time. And I think that, at best, this will be a great way to help physicians make better decisions about patient care. But I do think that we're getting into the peak of the hype cycle where people are thinking that, there are some medical specialties that we're no longer going to need in the future because of how good some of these AUC values have been in these published algorithms.
Yeah, interesting perspective. Really, really interesting.
Your Medium posts about Walmart and Amazon's healthcare strategies are some of our favorites. And a lot has happened since you wrote those posts, but what updates or revisions would you make if you were writing those articles today?
Yeah, I think at the time when I wrote the Walmart post, which is really what started just my thoughts about strategy in healthcare, they were thinking about merging with Humana or bringing Humana on as a partner. That has kind of since fizzled out. That being said, I do think Walmart has been a fantastic model for how to keep prices low and competitive in healthcare. And I think their footprint is unmatched by any other retailer in the country. And so something that I would today add to Walmart is a little more nuance in how they're competing with other players in the retail clinic space, including CVS and Walgreens. And I think they're all taking slightly different approaches. Walmart is really looking at capturing patients who are already going there for the rest of their shopping needs to also use them as a supplier of healthcare, whereas CVS has always been synonymous with pharmacy services and convenience. And I think that the retail clinic aspect of that matches that same type of convenience I was talking about earlier, where if 45% of millennials don't have a primary care physician, but if they're going into a convenience store like CVS to pick up anything they might need from the pharmacy, a bag of chips, anything else that they might need, but they can also get additional services there, then that becomes something where even if they aren't able to text their physician, they can walk down to the corner store and get what they need. And then finally, Walgreens has really been approaching this from the urgent care standpoint, where it's less about maintaining a relationship with a nurse practitioner or a PCP and saying, I immediately have a problem. Where's somewhere I can go where they can immediately give me an answer, or if not immediately give me an answer, at least tell me where I should be going instead. And so I think those are three different bets on what the relationship between patients and their care providers will look like in the future, as well as the immediacy of the answers that are expected of those care providers.
Yeah, and we've also seen a lot of the retailers really recently launch telemedicine partnerships, knowing that the convenience of the retail location on the corner is great, but not quite as convenient as if you could walk in and get it immediately, or as you were saying, have it on your phone. And it's intriguing to see these retail players who originally started with a retail clinic shift into more telehealth models, or really telehealth partnerships, as they become increasingly worried about, say, Amazon.
Yeah. Do you think from what you've seen over the last little bit with Amazon and some of the ups and downs that they've had, I mean, they kind of came out with a bang, but now there's some comments that maybe it was just a lot of bluster. We haven't seen a lot of impact just yet. What are your thoughts on how it's evolved or changed? Are you still bullish on Amazon's ability to execute on some of the healthcare vision they have, along with JP Morgan and Berkshire Hathaway?
Yeah, I think they're two separate approaches, right? There's the what is Amazon as a single entity doing in healthcare, which I think with the PillPack acquisition, they're able to essentially capture operating licenses in, I believe it was 49 states at the time, which was something that they had trouble doing themselves. And so something I wrote about was Amazon's earliest foray into healthcare was when they bought drugstore.com, which was famously unsuccessful, but was successful at selling cash pay medications, generics. And I think that same type of commodity retail that Amazon has been good at is at least applicable to some part of the pharmaceutical industry. I think the challenge for them now is dealing with pharmacy benefits managers, understanding that relationship and whether PBMs will and continue to see them as a threat, and then make the strategic decision to either slog through that fight and find one that will work with them, or decide to build their own PBM from scratch and use the consumer power they have from their many, many Prime members to say, hey, we have this huge base of demand. They're aggregating demand, and then using that in order to negotiate better prices for the drugs that they're able to, distribute via their private logistics platform. I think in regards to the Amazon, Berkshire, JP Morgan initiative, I find it to be very similar to what Walmart and Lowe's, Home Depot have done, creating these networks, these centers of excellence, and then having their employees fly to get certain types of specialty care like hip and knee replacements. That has been relatively successful for those large companies. And I think the strategy works when you consider Amazon, Berkshire, and JPM doing it for their own employees. If you think beyond the idea of just having their 1.2 million employees have lower healthcare costs, then that argument starts to break down, because it's just very difficult, almost absurd to think that you can operationalize the idea of having everyone fly to a select few medical centers to receive their knee replacements. At the same time, I think that that's a really interesting way for hospitals to no longer have to just think about competing in their own metropolitan areas, but have to compete nationally. So if all of a sudden the 1.2 million employees from these three companies are looking for one or two hospitals to get all of their orthopedic care, then all the major orthopedic hospitals in the country are going to be vying for their attention and have to compete on both quality and cost. And I think that type of, employer pressure on healthcare systems could be really interesting. The challenge is, of course, not all employees are happy with the idea of flying to a different state, a different unfamiliar healthcare system for their care. And oftentimes they'll think they need some sort of service, go to that center of excellence and be told that they would be fine with conservative therapy, and then feel upset because they wanted some intervention to help them feel better. So there's a very, very tight rope to walk there. And I think that it might depend on the size employer. So we might see more companies banding together to create similar models to what Walmart has successfully done with their employer health insurance plan.
Definitely. And I think the incentive to do so only increases as other large employers see their peers succeeding. So you mentioned Walmart, and I know they see 20% lower costs for those who go to their centers of excellence versus those who don't. And those employees return to work like a week and a half sooner than those who, say, get their knee replacement done not at a center of excellence. And I wonder what the tipping point is, because to your point, not everybody ever will get on a plane to fly to get their knee replaced. But at what point will enough large or jumbo employers create these COE partnerships that it creates a fulcrum shift in the market? I don't know that that's an answerable question, but just sort of a thought-provoking.
Well, Nisarg, you're a busy guy. You have a diversive curiosity, as you said before, interests in lots of different areas. Why the impulse to write? And how do you even find the time? How do you even find the time to sleep with all the things that you do and are interested in? But why the compelling need to write? And I just think it's so interesting.
Yeah, I think a lot of it has come out of the people who've inspired me. And so there's something about Indian male physicians and writing. And so it almost seems like every other Indian male who goes to medical school wants to be the next Atul Gawande, Siddharth Mukherjee, Paul Kalanithi, Sandeep Kaur. And so I think being able to read their work and both appreciate the depth of their explanations, their writing, but as well as the beauty of their prose was very inspiring. I think as someone who was a debater in high school, studied politics in college, the thought of being able to get my ideas out there, publicize what I was thinking was appealing, both in the context of what I was experiencing in the hospital, as well as my thoughts on healthcare strategy, healthcare policy. So I think that having those role models was definitely a big push for me to get started. And I think that once you get a few pieces out there, the bug just hits you. You want to keep going. And so for me, writing is both relaxing and also aggravating. I kind of agonize over outlining stories or structuring paragraphs or choosing just the right words to make a sentence flow beautifully. But it's also very satisfying to put thoughts down to paper, and very satisfying to see the work out there and to reach so many people. And I think particularly as someone who's still in training, it's really incredible and gratifying to at least be able to reach some people out there and change their opinion, make an impact, help them think a little differently about healthcare before I feel like a real doctor.
Well, you have had an impact, and we've very much appreciated your writing and hope that it keeps coming. Which leads to my next question: what's next for you, for your work, your studies, your research? What's on the horizon?
Well, I've got 6 more years of residency, so that's kind of locked me in, at least in San Francisco, for a while. I'm happy to be here. Like I said before, I like too many things, and so I could definitely see myself after residency going into policy, going into life sciences, healthcare IT, investing. There's so many options open, but I think one thing that has made me very happy over the last year or so is seeing how many of the people I look up to spend some time in one of those positions and then move into another. It makes it seem like you can spend anywhere from 5 to 10 years in one job, move to something tangentially related, but essentially completely different, and then do an amazing job in that role as well. And so one person I look up to immensely is Dr. Sachin Jain, who's the CEO of Memora Health. And when he was a resident, took some time off to go work in the White House in the Obama administration. And then afterwards, he spent some time practicing in Boston and then working at Merck. And now he leads Memora Health, which is a fantastic primary care system based in California. And seeing that kind of career trajectory makes me feel a little more comfortable with having no idea where I'll be in the next 6 years.
Awesome. Well, Nisarg, I don't know how much more my brain can handle. This has been awesome. We'll wrap things up. Thank you so much for finding time during your surgical residency to speak with us. It's been an honor, and I've learned a ton.
Thank you for having me. I appreciate it.
Thank you so much for your time today.
Thank you.
Well, this is Ben Tingy with A Sherpa's Guide to Innovation podcast. Thanks so much for listening. Tune in next time. Outstanding. Thanks so much, Nisarg.
Thanks. That was fantastic.
Yeah, well, we covered a lot of ground. Ann Summers and I were talking before we began. We easily could spend an hour or more on every single one of these questions and go really, really deep. But honestly, and this really isn't to butter you up, we
We really do love your work and your research, and start to salivate when your new Medium posts come out, and we greedily read them up. And so thank you for writing. Thank you for your work and how diverse of your curiosity is, because I think it adds a really unique perspective to have so many angles being considered.
Yeah, absolutely. I'm so glad that you found my work. Appreciate it. This was a really great honor, and I love being on the podcast with you all.